The Evidence for Change program was written into the original Clark Northwest Coast bid as part of the capacity building. At that point, it was called Team CPD, but it's based on some assumptions about that people would want to make changes in their practice. So the people in the NHS and in social care want to make changes in their practice. They might not have the evidence that they wanted to use it to use to make those changes, but that actually, if we had them working in teams, it would be stronger and it would be easier for them to identify the evidence they needed and make those changes in health and social care.
Good morning, everybody. My name's Jill Pope. I'm from Lancashire Care Trust and I work as a Practice and Quality Development Lead. This morning, my SHI team, who are helping out with the presentation, are Sarah Devlin, who's our Public Involvement Advisor, Karen Townsend, who is one of our ward managers in specialist services, and Sarah Beaumont, who is one of our ward managers on our acute mental health wards. There's also a missing member that I'll just make mention to because she has contributed a lot to this work. That's Tiff Sinclair, but she has gone over to UCLAM now. I also want to welcome everybody this morning that's come from both outside and inside our organisation to watch what we've got to say. We really, really value you making time to come this morning to see what we've been involved in. Our presentation, as you can see up there, is about us trying to create a harm minimisation approach across Lancashire, across the services that we have. And the aim is that we will change practice around the way that we help people and support people with their self-injury. I won't go through that list, but that is a list of people who have been involved in the work that we've been doing. And that group has been running for quite considerable time, really. We've been running from 2010, and we came together as a group of people that were considered to be a panel of experts, if you will, to try to develop a strategy around self-injury for the Trust. And one of the main reasons that we got together was because we wanted to provide a response to the NICE guidance, the 2004 NICE guidance around self-harm, and we wanted to ensure that as an organisation we were compliant with that. As a group, we didn't come together to think, oh, we're going to make sure we're compliant with that. We came together as a group of interested people who have a real passion for ensuring that people get the right treatment when they come through our services. I'd also just like to acknowledge a couple more people in that, Lorna Jellicoe-Jones, Alison Elliott and Pam Tester, because they have been involved in setting the scene and also creating that culture that's enabled us to carry out the work that we've done so far. So, as a smaller group, we have come together with this vision and with this objective, and that is that we wanted to support and promote the adoption of an evidence-based approach to self-injury and harm minimisation across all of our services, so the whole patient pathway, including community and inpatient services, so that every patient and service user can expect a consistent and helpful approach from a supportive and confident member of staff. So in light of what was shared in the previous presentation about inpatient admissions for young people being 3 times the national average, we feel that we need to respond to that. And I think that we need to make it really clear in there that inpatient admission is not always the right thing to do for anybody who self-injures, and harm minimisation runs across the whole care pathway. So what we've done so far is that we held a conference. As part of that conference, we got together a specification for some training. We actually developed an online training package, which to date has had 1,822 hits. We also developed a level 2 intermediate face-to-face training package that we've had 180 of our staff go through. That was delivered by an external organisation, and we have a member of that organisation here today, Claire Shaw. Thank you, Claire. And we've also developed a self-injury resource booklet, which was developed by 2 of our members, and that has received a BMA commendation. We've also got a policy as a result of the work that we've done that's just waiting to be ratified now. So we've actually achieved quite a lot. And I'm now going to hand you on to Sarah Devlin, who's just going to set some of this into a bit of context for us. Thank you, Sarah.
Okay, not nervous at all. This slide, it's quite complex, but it's to illustrate the complexity of the organisation and the complexity of the task that we had. So when Lancashire Care originally formed in 2002, it was a trust that solely focused on mental health, and since then it's grown quite dramatically in size. And it now includes a lot of community services that have traditionally been provided by PCTs. So within the structure of the trust, we've got 4 networks. We have the Adult Mental Health Network, the Adult Community Network, the Specialist Network, and the Children and Families Network. So we have services as varied as mental health community services, secure and inpatient services, prison and offender health, school nurses, podiatry, speech therapy, smoking cessation, and loads more. So with an organisation of this size, with such variety of services, we had a massive challenge on our hands to create a policy to cover the entire trust. So, I like this slide. I get the good ones. We realised that before starting the Evidence for Change programme that we were really, really good at being really busy and running, but not really getting anywhere, like our little hamster on his wheel. And then we got a bit hamster focused. And we realised that taking part in the Evidence for Change programme meant that we could swap our hamster wheel for our hamster dragster and actually start getting somewhere. So the Clark Evidence for Change programme has helped us to get moving by giving us dedicated time, both during and in between the programme days, to actually sit down together and talk and work through things together. Having the support and the experience of the staff from the Clark and having them point us in the direction of further sources of information and support has helped us to focus more and to think about our course of action in ways that we hadn't thought about before. And finally, the rigour and validation of the research process helped us to focus on actions, and beginning with the drivers for change, which Karen's going to talk about.
Okay. Oh, in the wrong way. Okay. So thinking about our drivers for change, as Sarah and Jill have said, the self-injury group in LSFT have been running for a number of years, including a number of interesting people who mainly, aside from the interested, did I say interesting people? Like interested and interesting people, yeah. And I guess as Jill said, there was one of the reasons they were together was around making sure the NICE guidance was implemented. However, the main driver, the main motivation of the people working in that group was because of that commitment to improving outcomes for people who use our services, for being conscious of the difficulties that people who present to us who self-injure experience, and understanding that sometimes our services don't always get it right, and we sometimes respond in ways that are unhelpful. So that basically is our first driver of change. So having a commitment to making sure that the services we provide, the input we provide to people improves quality of care and patient experience, service user experience. But along the way, I guess, at risk of sounding really cynical, but sometimes it's difficult working in the modern NHS, is that, I guess, although Jill commented that the group had achieved a lot of different things from about 2010 onwards, really making a massive change across the trust that brought about some difference was quite difficult, wasn't it? And it was kind of so dependent on people's enthusiasm and interest and where it kind of stood in the agenda, I guess. But interestingly, over the last 12 months, that kind of coincided with us coming on this Clark programme, issues around how we work with self-injury started to take the headlines a little bit, I guess. And so once it sort of starts hitting different people's agendas, then other people start to get interested in the work we were doing, and the kind of motivation and impetus increases. So, for example, there's been a current, I guess it's been driven by the Department of Health and Royal College of Psychiatrists push to reduce restrictive practices. And that's looking at, particularly in inpatient mental health services, thinking about the approaches that we have to managing risk. And historically, those kind of approaches have generally been around stopping people doing things, about laying blanket rules in place, being very restrictive to people, taking control away. And there's more and more recently been a push towards reducing restrictive practice. And that's about our interventions being proportionate to the risk we're managing. So that's one of the drivers. A driver toward harm-free care, so recognising that sometimes some of the previous approaches to self-injury have often done more harm than good, which we come to a bit when we look at our slide that's about our poster and the evidence that we gathered. Another factor that influenced us needing to kind of get on with the work and produce a policy and make sure we got an approach was around the Trust adopted a sequin target around it. I'm not sure if you don't work in healthcare what that is, but basically it's about we get paid some money from the government to provide our services if we do something that we set out to do. So one of the things that the evidence showed us was taking the older, more restrictive approaches to managing self-injury. It was more likely that they would increase violence and aggression. So basically, how people have previously approached people who self-injure is that they take things away, maybe restrain people to stop them doing it, act in ways that are shaming and blaming. And basically what our evidence showed us in our inpatient units particularly, that is if we adopt that approach, then incidents of violence go up and incidents of restraint go up. And so there was a clear correlation shown in that. And so it was decided that the evidence shows that if we adopt a harm minimisation approach, then it's likely to bring down our instances of violence and aggression and subsequent restraint. There's no towards CQC action plan, so all healthcare settings are subject to CQC inspection, and occasionally we get told we're not doing things right and we're encouraged to do things slightly differently. So they've had some kind of influence in this. One of the things that dropped out as well is about staff well-being. I guess, again, when we come back to the post that we've done, I guess it's understood that previous approaches to how we manage self-injury, as we said, can create more difficulty. It can impact on the relationship that staff and service users have. There might be more incidents of restraint, more incidents of violence, and in turn that impacts on staff well-being. Staff lack confidence in what they're doing, staff have difficulty managing relationships, and staff are likely to get hurt if they're constantly, as our service users, of course. And we focused a bit when we started this programme about challenging health inequalities, and at first I think we were giving that some thought about how we articulated that. But I guess it's about recognising that many people who present to our services, to mental health services, and those who self-injure, have often been, as the first group talked about, have often been subject to a great deal of disadvantage and difficult early life experiences. And I guess if we don't kind of think about having a consistent approach that bears that in mind, then we're at risk of reenacting that power imbalance that can make matters worse for people. So where did we start? So basically what the start of our process was about accepting that alternatives to a purely preventative or curative approach to accepting that there are alternatives to a purely preventative or curative approach to self-injury, and recognising and support the use of safer self-injury and harm minimisation approaches by staff, as long as such approach has been assessed and identified as the most clinically and ethically and risk management appropriate intervention. And accepting, for the first time in a lot of services, that for some individuals self-injury may represent a long-term coping strategy, and they might not wish to change or be able to change in the short, medium or longer term. So finally coming to what we've put in our poster. So again, going back to this bit where we gathered the evidence about why adopt our minimisation approach. So initially, like we said, we were thinking that the benefits of doing this was for the service users and for the quality of care that we provide. But when we kind of thought about it and looked at the kind of knock-on effects of that, there's actually sort of benefits for services and for staff as well. So rather than talk to this, I think we'll leave that bit to the poster presentation, but this really is about kind of emphasising the evidence of why we have adopted a harm minimisation approach. Sarah, do you want to?
So in terms of the methodology and the work focus that we had, we came together both in a virtual way and also as a group, as many as we possibly could, to look at the development of policy and our best practice guidance, and to look at a strategy and also a business case. I think as the other groups have said, and as Karen's touched on as well, it's often difficult to find the time within our busy sort of schedules and workloads to be able to get together. But I think what the clerk did was it enabled us to give us the foundations to be able to link together and to be able to prioritise this in terms of making sure that our project was successful. So the results. So what we did is that the clerk gave us a platform and they supported us in terms of looking at the literature and the evidence base that was available to us. And then we started to distill the knowledge and the evidence from the literature to create this policy to start looking at supporting a harm minimisation approach to self-injury. We produced this detailed review protocol, provided evidence that the proposed change in practice will provide a better experience for patients and service users. And then as part of that, we looked at potential other areas for research as well. And as Karen suggested, some of those areas was looking at about our patient experience, the feedback from the patients in terms of the way in which we were nursing them, and also looking at other areas such as potential reduced length of stay, less use of restraint, shorter admissions, and potentially looking at less 28-day readmissions as well. So what were the challenges? So it's a big task that needs strategic oversight with dedicated support, commitment and leadership. And within our group there's lots of commitment, lots of passion, lots of experience, but I suppose what we need now and what we're asking for is the support from the people that are higher than us and have that power to be able to rubber stamp what we've put together and enable us to empower others to adopt this approach. And we acknowledge that it remains controversial and easily muddled subject area, and that developments will involve inevitably ongoing tensions, debates regarding duty of care, capacity and consent issues. And we do understand all that. But we hope by implementing this policy and this procedure, by having additional training, experts, and about looking at how we manage staff anxieties in terms of, delivering these interventions, we hope that that will reduce some of the challenges. There's also some areas where there's a risk-averse culture is evident. And I see that on a personal level, day in, day out, in terms of, working with groups of people who do present with risk-taking behaviours. And part of this is about challenging that, managing staff anxieties and having a clear policy guidance and implementation plan to support people in their practice.
Thanks, Sarah. Okay, so what's next? So we've got our policy that we need to move into an implementation phase, and we need to implement that across a whole organisation. But how are we going to measure the impact of that? Because we can't just send that out willy-nilly and expect there to be this massive change. So what we need to do next is to actually measure the impact of that. So we need to find a cohort to work with that policy implementation with. As part of that, we'd like to have some advanced learning and development for specific practitioners around harm minimisation, particularly formulation and care planning around managing self-injury, and again across the pathway, so not just focused on inpatient services. We would like to be able to use, we use something which we call a 5P formulation. That forms the basis of our risk assessments, and we would like to use that as part of that process. And we would like to have some specialist advisors in teams who've got a special interest in self-injury to support groups of staff and also family and friends to work around self-injury. So again, this is about us taking it forward and just being really clear about the measurable impact of that, and asking for the help really and support from our organisation to help us to do that. Thanks very much.
Well, I think the teams have done a stunning job. They've done all of the things that we asked them to do. The history of the Clark is that it has to deal with health inequalities, and there has to be public engagement, and that's happened across the themes. It's identified some challenges in all of that, but actually it has all grown. The teams have done things like patient and public involvement in different ways. We can't judge that as successful or not successful. It worked for their teams and worked very well for their teams. So it's really contributed to the work of the Clark in terms of looking at health inequalities, patient engagement, and changing practice to improve the population's health.